I came. I don't know what's going on right now, but I hope vaccination things are going on, and hopefully the COVID situation is under control in that part of the world. I heard earlier in Chandigarh there was one time when there was some spike in cases, and there was something going on. So Nadim, you are doing this once a week or once a
No, right now we are having.
How often do you do this?
Lectures. We are having lectures almost four days a week as of now. We have a lecture tomorrow,
4 days,
which is on Europath, and then on Friday we have a lecture by Santosh Menon, who is in TMH, one of our alumni of PGI, who's very good in Europath. So he's taking a lecture on slide seminar on gynae pathology. The gynae is also his area. So Saturday we are not having any lecture because that's the time when AIMS has their monthly lectures. So we don't keep it on Saturday.
Wow.
So Saturday will be AIMS monthly lecture series. And then from 1st of February we are starting the respiratory system. So it will be whole of February will be respiratory system throughout. So which talks from Rajiv Kaushal and then Indranil and then Shukanto and then we have Dipali Jain and then we have Sanjay Jogai. All these people, Akriti Bansal. Then Minmoy will take some lectures on FNSE of the GI as well as lung and all that. So just trying to work it out. Then we have in March 11th, we have a lecture from Sanjay Kakkar.
I see.
Yeah. March.
Now, is Minmoy still in the Middle East?
Yeah, he's in Kuwait. Minmoy and Anupama both.
He's in still Kuwait.
Yeah. So we'll start. We are live on YouTube right away. Sir, you ready?
Yes, I'm ready.
Just give me a second. Right, so we start. Good evening, everybody. Welcome to this evening episode of Pursue 6Z, and it is liver and GI pathology. And we are streaming live from Yale University School of Medicine, USA, via Kolkata. And today we have a very important topic, and to moderate the topic, we have a very young, budding, very bright pathologist, Dr. Sunaina Mishra, who's a postgraduate from PGI Chandigarh, a PDCC in hepatopathology from the famous ILBS Delhi. Presently, she's an assistant professor in the Department of Pathology at the Atal Bihari Vajpayee Institute of Medical Sciences, Dr. RML Hospital, New Delhi. Dr. Sunaina Mishra has taken an important lecture on this forum, which was pathology of the gallbladder and EHBD. So who better than her to moderate this session? So I would request Dr. Sunaina Mishra to take over and introduce the speaker, Dr. Dhanpat Jain, and take it up from there. Dr. Mishra, please take over and start.
Thank you, sir. Good evening, everybody, and good morning, sir. So today it gives me immense pleasure to moderate this session on biliary proliferations, what is benign and what is not. And this is going to be taken by Dr. Dhanpat Jain. And Dr. Jain, he needs no introduction, but it is my proud privilege and big fangirl moment that I have been given this opportunity. He is the director of program in gastrointestinal pathology at the Yale School of Medicine at Connecticut, USA. Dr. Jain graduated from Mysore Medical College in India, receiving his MBBS degree in 1986, and he received his MD Pathology from Pgimer Chandigarh in 1991, following which he went to the US and completed his anatomic pathology residency and fellowship at GI Pathology at Yale University School of Medicine, and he is continuing his faculty there. Dr. Dhanpat Jain is a nationally, internationally recognized gastrointestinal pathology, and he has more than over 100 publications in many book chapters, many of which are landmark publications in GI and liver pathology. He has delivered many lectures, participated at courses at national and international level, and also he is an accomplished teacher, having received many awards, and has been continuously nominated for Best Doctors in America awards for many years. So without wasting much time, I would request Dr. Dhanpat Jain to start his presentation. Sir, please.
Thank you, Sunaina, and thank you, Nadim, for this wonderful opportunity. And it's great to connect to everyone through this forum. It's a real pleasure to talk about certain things that I am very passionate about, and I not only involved in the clinical world dealing with these things, but also from a research point of view. Also, these biliary neoplasms and biliary tumors are something that I have been involved for many years. So, can you see my screen now?
Yeah, absolutely clear.
Okay, great. So today I am going to talk about the diagnostic approach to biliary neoplasms, and take it up from both biopsy and resection point of view. And through some case examples, we will talk about various biliary neoplasms and the key features of each tumor, as well as when you see them in clinical practice, what are the challenges and how you overcome those issues. So starting with the first case, this was a 62-year-old man with 1.5 centimeter subcapsular liver mass. Patient had a history of hepatitis C, but had no history of cirrhosis or any clinical features of cirrhosis, and biopsy was performed. Now, I provided this history particularly with regards to cirrhosis because that's a very important feature when you're dealing with hepatic masses. And I think when you deal with the differential diagnosis of hepatic mass lesions, that history you should try to get one way or the other. In fact, one of the practices that we have here, and we have discussed this thing with our radiologists and clinicians many times, that whenever the status of the background liver is not known, many times when they're biopsying the mass in the liver, they will do a biopsy of the background liver at the same time. And that tells you how important it is to know the status of background liver. And right up front, one can tell that once you're dealing with a mass in the cirrhosis setup, by and far, the most common lesion that you deal with is hepatocellular carcinoma. Although other things, cholangiocarcinoma or metastasis, do occur in cirrhotic livers, but practically by far and most common thing that you deal with in cirrhotic liver is hepatocellular carcinoma. Hence, this particular piece of history is always very important. So this is the biopsy from that mass, and this is a low magnification view. What you can see is that difficult to make out too much at this magnification. You see some areas that look little blue, and these are probably all small inflammatory cell infiltrates. In these areas, you can see some sort of strands of some tissue. You can probably see some amount of what looks like normal liver here and here. So as I said, not too much you can say at this magnification, but it gives you a bird's eye view of what you have in the biopsy. Higher magnification shows you that the lesion is composed of small regular duct-like structures which are sort of round or oval, and they're more or less uniformly spaced. Very important to look at this border, which is the border between the this ductular proliferation with the hepatic parenchyma. And what you can see here is that the border is fairly nicely demarcated, and the lesion sort of is respecting this border. It is not infiltrating into the adjacent liver parenchyma. There are many other things that you should look at at this magnification. One, the spacing of these ductular structures is fairly uniform. They are not they are crowded, but they are not like back to back or forming very fused or complex structures. There is a modest amount of stroma in between, which is kind of sclerotic or fibrotic. And at the periphery, there is sprinkling of these lymphocytes, and that's why on low magnification, you could see there was some blue at the periphery. So at this kind of magnification, you know that you're dealing with some form of a glandular ductular lesion, and the key things would be to know whether this is benign or malignant and where this is coming from. This is the low magnification to again highlight few other important features. So in other areas of the biopsy, one could see far more dense sclerosis in the background, as you can see here. This all pale pink stuff is hyalinized collagen, and in the middle of this, you can see a lot of these same ductular structures, which are somewhat, you can say, irregular in some ways. They are, inverted Y-shaped or Y-shaped, L-shaped kind of structures. In some of them, even at low magnification, you can see the lumen. Few things to note again. One, you see the border with the normal hepatic parenchyma, which is fairly sharply circumscribed. The lesion is not infiltrative. You can see a rim of inflammatory infiltrate. These are the residual native portal tracts, and I've marked them like this. So you can see that the portal tracts that are present still have maintained their organization and structure. And if you pay attention, you can identify them. And this is a key feature to know that in most of the malignant lesions, the tumor generally tends to overrun the underlying normal structures, including portal tracts. If you see regularly interspersed portal tracts in these lesions, and you can still identify them, it is generally a feature towards a benign lesion, not necessarily always. Sometimes in malignant lesions, you can see a residual portal tracts still present. But by and large, if you see this kind of phenomena, it is a soft pointer towards something being benign. This is a higher magnification again to show the areas that on low power look like highly sclerotic. Under high power, you can see this dense fibrosis. One can call this desmoplasia. Desmoplasia just means fibrosis, but the moment you use the word desmoplasia, everybody thinks of tumor desmoplasia and malignancy, which is not entirely true. You can see here the glandular structures, which are again fairly uniformly spread. They have somewhat angulated profiles, and that makes you wonder about a malignancy. You can think about something along cholangiocarcinoma. There is this dense fibrosis, which also points to a cholangiocarcinoma. But what you see here is that they are respecting this border with the native portal tracts, and somehow the spacing of the ductular structures is still fairly uniform. And at this magnification, the other thing which you can see is that not much of nuclear pleomorphism or nuclear atypia in terms of very large nuclei, pleomorphic nuclei, or prominent nucleoli. And again, this is higher power to show you the same things, that the cells are relatively uniform. They don't have those nuclear atypia features that I just mentioned. You don't see mitotic figures, and overall the cytology of the lesion is very bland. This is the Ki67 stain, Ki67, which indirectly gives you the proliferation marker, proliferation index. As I said, there were no mitotic figures on H&E stain, and overall the mitotic index was less than 10% when you did the counts. So in this setting, when you see all those features, your differential diagnosis is whether this is malignant, number one, which is cholangiocarcinoma, or this is benign. The benign counterpart in this this setting would be a bile duct adenoma. Yeah, when you see glandular lesions in the liver, metastasis automatically become one of the differential diagnoses. And in this setting, seeing the morphology, probably a conventional type of hepatocellular carcinoma in the not a differential diagnosis, but one can certainly think of a sclerosing type of hepatocellular carcinoma, although I would say that the cell morphology and gland formation is such that probably that is a little bit of a stretch. So we'll leave this at this point, and we'll come back to this case later. So let's look at another case, which is 57-year-old man with a 2-centimeter subcapsular liver mass, again with no history of chronic liver disease or cirrhosis. This is the resection of that lesion. Few things to note on the gross photograph. Number one, that the lesion is fairly well circumscribed, very round. It is, you can say, slightly pale yellow, tan colored, and you can't feel it on the photograph, but if you were to feel it, it would certainly have felt firm. The background liver looks fairly normal in appearance, and especially does not show any features of cirrhosis, which was also sort of mentioned earlier in the clinical history. This is the low magnification photograph of this lesion. Lot of similarities with the other lesion that I just showed you, the biopsy. What you see at the periphery of this lesion is most of the areas show fairly well circumscribed border. Towards the edge, you do see some sprinkling of inflammatory cells. That's why these areas appear slightly dark blue. There is uniform, a very uniform spread of these duct-like structures, which we'll see in high magnification in a minute. But low power gives you an idea. There is a fairly uniform spread of these ductular structures in a background that is somewhat sclerotic or collagenous. This is a higher magnification again to show the circumscribed border with the adjacent liver parenchyma, some inflammatory cell, and other features are fairly similar to what I showed you just now with that biopsy. So I'm not going to repeat that, but I'm trying to show lesions that are otherwise fairly similar, but we'll note some of the differences between those two lesions in a minute. Now, while most of the areas, the border of this lesion was fairly circumscribed, and respected the hepatic limiting plate in those areas. In some areas, you could see the lesion actually was infiltrating into the adjacent liver parenchyma, and this is one such area. Here you can see that this is the hepatic lobular parenchyma. You can see the hepatocytes in the sort of cord plate arrangement. You can see this area, the cells are infiltrating between the sinuses. In fact, here the cells have encroached into this hepatocytic parenchyma right here, even here. The other things that you can also note here, which is different from the previous lesion, is that many of the cells are highly pleomorphic. Even at low magnification, you can see the cells sort of stand out like this. And that is something which is concerning, and it's different from the previous biopsy that I showed you. This is the higher magnification to show you that while most of the lesion looked fairly similar to the biopsy that I showed you, there were areas where you had more pleomorphic cells, and the lesion was infiltrating in these areas into the adjacent liver parenchyma. This is a higher magnification to show you that there was pleomorphism within the lesion as well in certain areas. You can see many of the nuclei being very large, and the background otherwise looks fairly similar to the other lesion. There is a modest amount of background sclerosis, and actually after hunting, one could even find occasional mitotic figures in some areas. For example, one's shown here right in the middle. Maybe another one here. So again, both these lesions are very similar. They are ductal proliferation of some sort or glandular proliferation of some sort. They have many features that overlap or suggest the possibility of malignancy, particularly cholangiocarcinoma with background sclerosis and desmoplastic response that is very typical of cholangiocarcinoma. However, many of the features are very bland and benign looking, so one has to think of bile duct adenoma as a differential diagnosis, and metastasis automatically comes in the differential diagnosis. As I mentioned with the previous lesion, a hepatocellular carcinoma in this particular setting is probably not a realistic differential diagnosis, but I just kept it for the sake of discussion. So, what these sort of two cases highlight are what are the kind of practical issues that you face when you're dealing with ductal or glandular lesions in the liver. And again, when you say glandular or ductal lesions, we are talking about biliary lesions in the liver. So on one hand, we have to differentiate them from benign or reactive lesions, which are not neoplasms at all. Then we have to differentiate benign from malignant lesions, which means benign biliary lesions like biliary microhematomas or bile duct adenomas from cholangiocarcinoma. These also need to be differentiated from hepatocellular carcinoma, and practically once you know that it's a malignant, the most important and critical differentiation is from metastasis. So when you look at the classification of all the biliary tumors that you see in liver, these are shown here. Among the benign lesions, you have bile duct hematoma, or so-called von Meinberg complexes, bile duct adenomas, mucinous cystic neoplasm, which used to be called hepatobiliary cyst adenoma, but this is the new terminology in the recent WHO classification. And the malignant counterparts of these are cholangiocarcinoma. The malignant counterpart of biliary mucinous cystic neoplasm is biliary mucinous cystic carcinoma, or biliary mucinous cystic neoplasm with invasive carcinoma. This used to be called hepatobiliary cyst adenocarcinoma. Extrahepatic lesions we are not going to discuss today. Among benign ones that you can see, this is still very rare, but still among the commonest lesions in that setting is a granular cell tumor, and extrahepatic cholangiocarcinomas, again, that is not uncommon. So let's start with the benign lesions. Von Meinberg complexes. These are something that almost everybody is familiar with. These are not uncommon in clinical practice. These are very tiny lesions which are seen as white spots on the surface of the liver, like you see here. When you see the cut section of the liver, actually it's very difficult to identify them, at least most of them, because they are very tiny. They are usually less than 0.5 centimeter, sometimes even smaller. And only when you look from the sort of outside, because these two appear as tiny white spots, you can recognize them. But on cut sections, unless until they become cystic or larger, it's very difficult to sort of recognize it. I'm showing this liver here that on the surface you can see multiple of these tiny lesions. In fact, this liver had probably thousands and thousands of this lesion, but only on the surface you can identify them. You can't see them on the cut surface. And the other misconception is that these are present on the surface. No, they are present throughout the liver. They are most easily seen on gross examination surface. On the cut section, you don't see them at all here. But if you take sections, they are uniformly spread throughout the liver. This is a histology of a von Meinberg complex. Again, when they are present like this, they usually cause no problem in clinical, situation or settings. They are composed of this duct-like proliferation, which are irregular in shape. So Again, if you think of the lesions that I showed you earlier in those two cases, the differences are that the lesion, first of all, is well circumscribed, so that is good and supports the benign diagnosis. There is a sprinkling of inflammatory infiltrate at the periphery, which is common to many of the slow-growing benign lesions. Here, the ductular structures are somewhat more dilated. Their profiles are a little more irregular. Sometimes people call these as Chinese letters. I'm sure the Chinese people don't like that because these are probably nothing to what the Chinese letters actually are. But people who are not Chinese probably feel that that's a good way of describing this architecture. If you look at the background, it is fairly sclerotic, fairly collagenized. But the key thing again to look at is the uniform spread of the ductular structures. This is a higher magnification, again to show that these are composed of very bland epithelial cells, very banal looking cytology, very uniform. One of the key features of this lesion is that often you will see inspissated bile secretions or concretions within these dilated structures. Also note this kind of irregular profile anastomosing structures that are very typical of this lesion. As I mentioned, some of these lesions can become very cystic, and that's when they are recognized on imaging findings or gross examination. This is one lesion where the entire lesion, this was probably a lesion that was larger than a centimeter. The entire lesion was sclerotic and collagenized like this, what you see on this corner, with some degree of hemosiderin-laden macrophages and inflammatory cells. And only at the periphery one could see few residual structures that were suggestive of one-member complexes. And these lesions can undergo complete sclerosis, where they may only be recognized as tiny, small sclerotic nodules. And at that stage, it's very difficult to know whether this is a sclerosed hemangioma or this is a sclerosed one-member complex. Only when you see some residual structures at the periphery, you can probably suggest that this was a sclerosed one-member complex. Higher magnification, just to highlight the benign nature of the cells, very monomorphic appearance, uniform spread of cells, uniform spread of these ductular structures. The background collagenization or sclerosis certainly mimics cholangiocarcinoma, but still it is somewhat loose in some fashion, and still slightly different from a highly desmoplastic stroma of a cholangiocarcinoma. No mitotic figures, and if you were to do a Ki67 in these cases, it will be less than 10%. Now, that was a resection. When you see all the features, it is sometimes easier to diagnose, and practically it's never a problem. However, when you encounter them in biopsies, they can be somewhat more challenging. So this is one needle biopsy where they just picked up one member complex by chance. And when you look at this area, the things that bother you on low magnification are that this lesion has got sclerotic stroma. It has this very angulated, glandular structures, and on biopsy, sometimes the dark staining can make the nuclei look a little more scary. But when you look at higher magnification, there are a few things that again are generally helpful. One, that they have this kind of dilated kind of lumen in which you can see those secretions. These sometimes will form laminated concretions of bile. Even though at low magnification you can see some dark staining nuclei, if you look at higher magnification and pay close attention to the cytologic details, these are still very round, oval, bland looking nuclei, and you won't find any mitotic figures in these. So I think overall, if you pay attention to the cytology and the border of the lesion and the normal hepatic parenchyma, which is fairly sharp and circumscribed, you can make a diagnosis of benign lesion. But having said that, I can tell you that depending on how they come in biopsy, sometimes it can be very, very challenging. Now, This is something that you see in practice not uncommonly, and can be a diagnostic problem, especially if the clinical suspicion is that you're biopsying malignancy. Now, in any liver kind of an disorder where you have some injury, you often get ductal proliferation. Now, ductal proliferation can occur in a variety of primary liver disorders also, particularly disorders of biliary tree like primary sclerosing cholangitis or primary biliary cholangitis, or duct obstruction where you get tremendous degree of ductal proliferation. And these ductal proliferations in biopsies again can be challenging to differentiate from malignant process. Again, if you pay attention, the things that are very helpful are that there's a uniformity in the proliferation of these ductal structures. Although they are always seen at the very intimately sort of related to the peripheral hepatic plate or limiting hepatic plate, they respect those borders. They do not have an infiltrating border. And if you pay attention to the cytology, they are usually very banal looking. When there is benign ductal proliferation, although you can sometimes find mitotic figures, but overall the architecture of these things is so regular and uniform that one can clearly differentiate this from malignant neoplasms. And this is again from a resection where it becomes easier, but on biopsies, as you can see, this can be fairly challenging. One key thing to note is that most of the time this is not a problem, because when you get this kind of biliary proliferations, they are biopsies from a benign liver disorder, not from a mass, so that easily resolves the issue. However, sometimes they are biopsying a mass, and instead of hitting the mass, they hit the periphery of the lesion, where you can get this kind of ductal reaction, and that is the setting where sometimes you may have this problem where either the mass has not been sampled, they completely missed it, and what you're seeing is the ductal reaction in the periphery, or you may see both of them in the same biopsy, and to figure out what is the true nature of the lesion. This is again ductal reaction shown at a low magnification, to show that the ductal reaction that you see in many of these biliary conditions still maintains a lot of uniformity, and besides the bland nature of the cells that you see at higher magnification, the low power architectural configuration is probably the most important thing that helps you differentiate benign from malignant. I think when you start looking some of these things in higher magnification and cytology, sometimes due to inflammation or other secondary phenomena, on higher magnification, especially if you're doing a frozen section, these can mislead you. Always look at the low magnification and the architecture of the thing. So the other thing that sort of comes in the differential diagnosis of other benign biliary disorders is bile duct adenoma. These lesions are larger than one-member complexes and can be seen grossly. So this is one example where you see a lesion which is fairly well circumscribed, like the one I showed you earlier in the case 2. Looks very similar, and on higher magnification, this is in a cirrhotic liver. And you can see cirrhotic nodules, and in that you have this whitish lesion which is probably about a centimeter in size, and you can see this is different from the background cirrhotic nodules. Now, as I said, that when you see cirrhosis, your first reaction when you see a lesion or mass is that it is hepatocellular carcinoma. However, some other lesions can be biliary in nature as well. This is another example of a bile duct adenoma, where you can see this is a lesion which is slightly larger. It's, I think, almost about 2 centimeters in size, very similar appearing in terms of its color and appearance, and very well circumscribed. The background liver in this particular example is non-cirrhotic. Your clinical differential diagnosis when you see your on gross examination would be a cholangiocarcinoma, a bile duct adenoma, metastasis, even hepatocellular carcinoma. This is a very low magnification view of that particular lesion. Many things to note. One, the border with the adjacent liver parenchyma, very circumscribed. You can almost draw a nice line separating the lesion from the adjacent hepatic parenchyma. The periphery appears very dark blue because there is a rim of inflammatory infiltrate at the periphery. The center is more pale and pink because of dense sclerosis in the center. In fact, some of the lesions may show highly collagenized stroma in the center without any ductular structures at all. This is another example of a bile duct adenoma. You can see here the peripheral rim of the lesion, which has these collections of lymphoid aggregates, which gives this blue kind of color at the periphery. The lesion is composed of uniform proliferation of very small duct-like structures. Interestingly, at the periphery of this particular lesion in the same portal tract, you see a one-member complex. And this is useful because here you can see some of the differences between what we call a one-member complex or biliary microhematoma with a bile duct adenoma. The ductal structures in a one-member complex are often very irregular and dilated, whereas in bile duct adenoma they're much more smaller and more uniformly spread. Having said that, I would say that you see many lesions where there's significant overlap, and sometimes you can see a one-member complex at the periphery of some of these lesions. And I believe that many of these lesions probably arise from one-member complex, and there is a relationship between these lesions. And in some cases, whether to call this a one-member complex or a bile duct adenoma is sometimes more of a semantics. The key thing is that both are benign and otherwise inconsequential. This is a lesion which is smaller. This is something present on the surface of the liver, and you can see easily why on frozen section or a needle biopsy this can be easily confused with an cholangiocarcinoma. Ductular proliferation in a cholangious or in a very collagenized stroma. In this particular one, the border is somewhat irregular, although the proliferation is respecting the limiting plate. But if you draw the outline of this lesion, it will be very zigzag, and that either on gross or microscopy or on needle biopsies can be confusing. The key feature again is the cytology. In bile duct adenomas, the glandular proliferations are much smaller. They are almost like bile duct ductules with rounder oval profiles. You can see the lumen in some the lumen may not be visible. The cells lining these structures are very bland. They're low cuboidal or low columnar epithelium, sometimes flattened epithelium. Bottom line is that there is hardly any pleomorphism. You shouldn't be seeing any mitotic figures in these, and the uniformity of the cells should lead to a benign diagnosis. This is again to show you some of the key features of these lesions: low magnification, the circumscribed border, and the lesion respects the limiting plate here. These lesions can get heavily collagenized in the center particularly, and these are the areas where on biopsy it can be very, very challenging to differentiate from a sclerotic stroma of cholangiocarcinoma. If you look at the cytology of the cells, very bland cytology, and often these lesions will have a good admixture of inflammatory cells, particularly at the periphery where you can see even lymphoid nodules or aggregates. This is a high power to show you from another example to show again the bland nature of the cells and lack of any pleomorphism, cytologic atypia or mitosis. Okay. So Ki67 stain in these, I don't do them routinely in all cases, but sometimes when you are dealing with challenging cases, it may be useful. Tends to be on the lower side, generally less than 5%, but certainly less than 10%. Now look at some other lesions and try to see how these lesions are different from this particular example. So this is one lesion where you see the ductular proliferations have somewhat an irregular profile. They are like this Chinese letter pattern. that you saw with the one-member complexes. Some of them are dilated. You see the border of this proliferation with the hepatic parenchyma. It is irregular and jagged. This is a higher magnification, again to show you that this lesion here is sort of infiltrating into the adjacent hepatic parenchyma. Even a low magnification, you can see some degree of pleomorphism, maybe a couple of mitotic figures. I'll show you in high power here that these cells are now not so bland looking. They do have some cytologic atypia. Some of them have started very nucleoli. And as you can see that they are not respecting the border with the hepatocytes. They are actually infiltrating. And you can start seeing some mitotic figures in the lesion here. This is another area of the same lesion showing the cytologic atypia, how it infiltrates into adjacent hepatic parenchyma, and overall architecture of this one still looks like bile duct adenoma, but these are the features that are not typical of bile duct adenoma. So this is a lesion that should raise concern if you pay attention to the cytology, the architecture of this lesion. Even though this particular lesion was well circumscribed in most of the areas and looked like bile duct adenomas, in some areas this had this infiltrating features and atypia, suggesting that this probably had evolved into a cholangiocarcinoma. In that particular area, if you did the Ki67 stain, it would show you higher staining with Ki67 as shown here. It was, I think, in the range of 15% or something in this particular case. So these are the common benign proliferations that you see in practice that need to be differential cholangiocarcinoma, and I put the three things that are in the differential diagnosis and the key features that help you to differentiate those things. The things that one need to consider when you're talking about biliary proliferations, and the benign ones are the one-member complex and bile duct adenoma. The malignant counterpart is cholangiocarcinoma. Now, the key thing is, first thing is size. One-member complexes are generally less than 1 centimeter. Bile duct adenomas can be slightly larger, but still less than 2 centimeter size, whereas cholangiocarcinoma tend to be larger. Now, these are always rough guidelines. Some of the bile duct adenomas can be certainly larger than 2 centimeters, and some of the cholangiocarcinomas can certainly be less than 2 centimeters in size. But by and large, this size cutoff is a good hint towards the nature of the lesions. If you look at the architecture of the glandular proliferation, they tend to be curvilinear or irregular profiles with cystic change and inspissated bile in one-member complexes, whereas there are more rounded profiles without the cystic dilatation or biliary concretions in adenoma. Cholangiocarcinoma is highly variable, and that's where it can get challenging. On one hand, some of the cholangiocarcinomas have architectural features which are very similar to one-member complex, and those have been called as ductal plate malformation like cholangiocarcinomas, whereas others are more like the traditional just adenocarcinomas. Stromal hyalinization is a feature common to all of these lesions and cannot really help you in the differentiation. You can see a variable amount of inflammatory infiltrate in the background in all of these conditions. That also doesn't help, but relationship with the periphery with hepatic limiting plate is very important. In benign lesions, the biliary proliferations respect the borders and are not infiltrating, whereas in cholangiocarcinoma, or when cholangiocarcinoma develops in one of the benign lesions, that relationship is lost, and any infiltrating growth pattern should be looked with some degree of caution and more care. Mitotic figures are not seen in the benign lesions, whereas they can be present in the cholangiocarcinomas. Cytological atypia and pleomorphism, again, not present in the benign lesions, whereas in the cholangiocarcinomas they can be very variable, and some cholangiocarcinoma which are very well differentiated can have minimal cytologic atypia, whereas others will have more. These lesions generally have no necrosis, whereas cholangiocarcinomas can have necrosis. P53 I don't use in our practice for differentiating benign or malignant lesions, but at least per literature, P53 tends to be weak or rare staining in the benign lesions, whereas it can be variable or strong. Now, what it implies is that when you see a weak or negative P53, it doesn't help, but if you see very strong and diffuse P53, probably it is a cholangiocarcinoma. As I say, mitotic rate is very important. Generally, don't see any mitotic figures, and if you do Ki67 stain, it tends to be less than 10% in the benign lesions. But again, in cholangiocarcinoma, the Ki67 is also highly variable. It can be low, it can be high. The key point is that if it is high, then it certainly points towards cholangiocarcinoma. Again, I don't use P16 in the differential diagnosis, but some people have tried this and suggest that P16, when it's absent, points towards a diagnosis of cholangiocarcinoma. So that was the sort of overview of how to differentiate some of the benign bile duct lesions from the malignant bile duct lesions. There are some other biliary neoplasms that one should know about, which can be encountered in a clinical practice and have some unique or characteristic features which help with the differential diagnosis. One of them is biliary mucinous cystic neoplasm. These were called hepatobiliary cystadenomas. These are very similar to their pancreatic counterparts, which are called pancreatic mucinous cystic neoplasm. The lesions are cystic. They are sometimes made up of only few cysts, sometimes made up of very complex multilocular cystic structures. The key thing, similar to pancreatic neoplasm, is presence of this ovarian-like stroma on which you have an epithelium which is hepatobiliary type, columnar sitting on that, which can range from very benign, when these are called benign mucinous cystic neoplasm, or can become malignant. As long as it's non-invasive, it's probably all good. They are still benign, but once you start seeing invasion, depending on the degree of invasive component, this can behave in a more aggressive fashion. So these lesions are encountered sometimes in clinical practice, especially at the time of frozen section, when they send the wall of a cyst largely to make sure, one, that this is not a mucinous cystic neoplasm, and you're looking for ovarian stroma in that setting, because once you say there's ovarian stroma present, the clinical significance of that is that they have to remove that cyst in entirety. Whereas for many other benign cystic lesions, they just simply de-roof the cyst to decrease the pressure, and they don't worry about the completion of the resection. So in frozen section, the key thing is, most of them, the epithelium is denuded, you don't even see the epithelium. The key is to make sure that there is no ovarian stroma present. Biliary adenofibromas, again, these are very rare lesions. I haven't seen an example myself. These really look like lesions that are composed of multiple tiny cysts, almost giving rise to a sponge-like appearance to the lesion, and composed of tiny cysts lined with very bland-looking biliary type epithelium. And again, once you see the lesion, I think usually making benign diagnosis is not a problem. The most critical thing is that ensuring that there's no malignancy present and you are aware of this entity. This is, again, in some ways very similar to serous cystadenoma that you see in pancreas. And coming to the big thing in this setting is the cholangiocarcinoma, where again, this is a major diagnosis in the liver. This is the second most common epithelial malignancy in the liver. Occurs in elderly, generally between 5th and 6th decade of life, with no specific gender predilection. The important thing to know about cholangiocarcinoma, as opposed to hepatocellular carcinoma, is that these often arise in the setting of non-cirrhotic liver, and hence the presentation is often late, and when they present, often it is diagnosed at an advanced or late stage, where often the treatment options are fairly limited. Clinically, the important thing to remember is that alpha fetoprotein is not elevated, which is the tumor marker for hepatocellular carcinoma. CA 19.9 or CA may be raised, but they are not specific. Key thing to again remember when you're talking about tumor markers is that if you see a lesion on histology that looks like cholangiocarcinoma, but alpha fetoprotein is elevated, there are two things that you have to consider. One, that it could be actually a mixed tumor, a mixed hepatocholangiocarcinoma where only the cholangiocarcinoma part has been biopsied, or whether it could be a germ cell tumor in the right setting or not. Cholangiocarcinoma, 80% of them tend to occur in livers that do not have cirrhosis or any known predisposing condition. So in that setting, knowing that the liver, background liver is normal or has no background liver disease is important, as I said earlier. However, this does occur in conditions that in some ways are related to biliary injury or bile duct proliferation. Chronic cholangitis from any conditions, most likely PSC or primary biliary cirrhosis, can be predisposing condition for cholangiocarcinoma, hepatolithiasis, liver fluke infestations, which again reside in the biliary tree. Can be chronic inflammation, can lead to chronic inflammation and injury to the biliary epithelium, leading to cholangiocarcinoma. Various type of ductal plate malformations that include various type of hepatic cyst, Carolus disease, congenital hepatic fibrosis, and even von-Weinberg complexes, which are considered part of ductal plate malformation, are predisposing risk factors for cholangiocarcinoma. Among various toxins and drugs, again, we don't see that often, but some of them have been associated, as listed here, with cholangiocarcinoma. The cholangiocarcinomas have been traditionally divided into three types based on their location, which clinically is still an important distinction because the management of these tumors varies depending on the location. Intrahepatic or peripheral cholangiocarcinoma is something that is inside the liver. The one that occurs with or which occurs right at the hilum, at the bifurcation of the bile ducts, is called the Klatskin tumor or the hilar cholangiocarcinoma, and this has special relevance to people at Yale because Klatskin was a hepatologist at Yale. He was actually the first hepatologist who started the branch of hepatology at Yale, and there are quite a few things that go by his name. He was pioneer. He sort of promoted the practice of liver biopsy for the first time, and we still have a library of liver biopsies and liver photographs that he took. He was not a pathologist, but he was very much interested in histology of liver and was deeply involved in liver biopsies. And we do have so-called Klatskin library at our place. He was pioneer in many ways in the liver disorders. Extrahepatic cholangiocarcinomas are those that involve the extrahepatic bile duct. Now, that was based on anatomic location. Now, in the new WHO classification, the cholangiocarcinomas has been divided in two types, a small duct type and large duct type. Now, at the outset, I would say that this distinction is sort of interesting because it highlights two different forms of cholangiocarcinoma, which are very different in their sort of pathogenesis and histomorphology and immunophenotype and molecular findings. In practice, it really doesn't matter. And I think we don't subclassify our cholangiocarcinoma as a small duct or large duct type, and I haven't seen anybody else doing it here in the United States. Probably in some of the centers where this research was done and where they came up with this classification, they do it routinely. But conceptually, the small duct type cholangiocarcinomas, those that are actually what we used to call intrahepatic cholangiocarcinomas or peripheral small duct cholangiocarcinomas, and in this you do have different risk factors. For example, small duct cholangiocarcinomas are often associated with non-biliary cirrhosis or chronic viral hepatitis, whereas large duct types are associated with primary sclerosing cholangitis, hepatolithiasis, or liver parasitic infections. Now, again, one, if you think broadly, the large duct type are the ones which combine the hilar and the extrahepatic ones, with the small duct type are the peripheral or intrahepatic cholangiocarcinomas. And based on that, you can see what the differentiations are actually. These tend to form large ductal or tubular structures with desmoplastic response like any other conventional adenocarcinomas, whereas the intrahepatic ones have a very distinct architecture with tubular structures or glandular things that have more anastomosing cord-like pattern. And in these, sometimes the luminal structure is not visible or is only slit-like, and the visual appearance of these are slightly different. There are subtle differences in the immunohistochemical and molecular findings in these two tumors. Again, we don't do this routinely. There are things that are common to both neoplasms, which are the staining for EMA, which is MUC1, CK7 and CK19. Both of them stain similarly, whereas the small duct types tend to be positive for NCAM, EpCAM, NCADRIN, and they tend to show IDH1 and 2 mutations on molecular analysis. Whereas the large duct type are positive for the gastric phenotypes like MUC5 and MUC6 positivity. They are positive for S100P, sometimes TFF1, AGR2, MMP7, and KRAS mutations. So at molecular level, there are certain differences which may become important when you are thinking of targeted therapies at later on. Cholangiocarcinomas may have different growth patterns. What you see here is a mass-forming cholangiocarcinoma, which looks like more gray to white firm mass lesions in the liver that often are seen in a non-cirrhotic liver. This is a lesion which is periductal growth pattern, where you can see on a cut section the tumor is actually following the bile ducts, and all this white you see, some of it is fibrosis from inflammation and reaction, but some of it is actually tumor. You really don't see a single mass lesion. And what it also causes is that when this causes obstruction, it causes cystic dilatation of the other ductal structures in the background. Here, this is the bifurcation of the ducts, and there's a tumor here, which you cannot see visually, but if you were to see and feel this thing, you will see that the duct is thicker and firmer, and this is again periductal growth pattern in some ways, but because of the location, this is the hilar or clad skin tumor of the liver. This is another unique pattern which is interesting. You see the tumor growing inside the bile ducts. The bile ducts are markedly dilated, as you see here, and there's a fleshy, very, very soft growth that extends all the way inside the bile ducts. This is the intra-biliary cholangiocarcinoma or intra-biliary papillary neoplasm, like very much like what you see in the pancreas. Histologically, most of the cholangiocarcinomas have this typical adenocarcinoma pattern with a lot of glandular sort of structures infiltrating through the desmoplastic stroma, which is the characteristic feature of these tumors. These tumors also have the propensity to invade the nerves. As you can see here, there's a lot of perineural invasion. This was one of the hilar cholangiocarcinoma, which is the large duct type in the new WHO classification. This is a tumor that can be sometimes confusing by both its morphology and nomenclature. What you see here is a tumor that is composed of very bland looking epithelium. Many of the ducts are irregular and dilated with inspissated secretion, mimicking so-called the one-member complexes that we discussed earlier. Many of the features are similar, but as you can see, there's a lot more epithelial proliferation than a typical one-member complex. There are many structures that are much smaller and have an infiltrating kind of a feature. This is a big mass lesion, and these kind of tumors that resembled this very low-grade cytology, well-differentiated histologic pattern were called cholangiocellular carcinoma. Earlier, these were considered to be some form of a stem cell differentiation or a part of mixed hepatocholangiocarcinoma, but that has now been changed in a new WHO classification, largely due to the efforts of Dr. Sanjay Kakkar, who showed that these tumors actually are no different from cholangiocarcinomas at this molecular level, and just represent probably a well-differentiated form of cholangiocarcinoma. So in a new WHO classification, so-called cholangiocellular carcinoma is considered as a well-differentiated pattern of just cholangiocarcinoma. This is an example of a intraductal cholangiocarcinoma, where you can see this papillary growth within the duct, which is markedly dilated. The surrounding part of this duct is highly sclerotic, and there is some atrophy of the liver parenchyma around that, but there is no invasion, at least in this example. Like the intraductal papillary mucinous neoplasms of the pancreas, the key feature is to look for the atypia within the epithelium, as well as the presence of invasion into the surrounding stroma. The cholangiocarcinomas can have varied cytologic and growth patterns, and one need to be aware of those so that you can keep cholangiocarcinoma in their differential diagnosis despite the unusual appearance. Shown here, this is a clear cell cholangiocarcinoma where the cells have very clear cytoplasm. When you see something like this, immediately clear cell renal cell carcinoma or even a clear cell hepatocellular carcinoma come into differential diagnosis. In many areas, obviously, you can see some degree of conventional cholangiocarcinoma also, but sometimes that may be completely absent or a minor component of the tumor. So in this kind of a setting, clinical knowledge as well as the immunohistochemistry becomes important. This is a cholangiocarcinoma which has this architectural feature that mimics ductal plate, where there are anastomosing cords of this biliary epithelium with this inspissated secretion and dilated lumina, very much like the cholangiocellular carcinoma that I showed you. When this is somewhat like this, some people refer to this as ductal plate-like cholangiocarcinoma. Again, no specific significance other than recognizing this growth pattern. These often are well differentiated, and if their entire tumor is like this, they have a slightly better prognosis than conventional cholangiocarcinomas. Some of the tumors can have very dense lymphocytic infiltrate in the background when they are called lymphoepithelioma-like cholangiocarcinomas, and in this setting, some of them may be associated with EBV, and this is somewhat similar to what you see in nasopharyngeal carcinomas or gastric adenocarcinomas, which have this rich lymphoid stroma. Again, it's only in a subset, I think less than 1/3 of these tumors that you see EBV. Some of the cholangiocarcinomas can have very hepatoid appearance or oncocytic appearance as shown here. And although in this particular example you can see some glandular structures or glandular differentiation, some of them can appear very solid and confuse one to think that these are hepatocellular carcinomas. Again, in this setting, the immunohistochemical markers can be very helpful, especially in needle biopsies. If you see resections of these tumors, it's very interesting that in many cholangiocarcinomas, you see this kind of an solid growth pattern at the periphery of the tumor, and when you look at the center of the tumor, they have the classic cholangiocarcinoma pattern. So sometimes when you resections, you can observe that very nicely, and sometimes people start thinking these are mixed tumors. They are not. If you do immunohistochemical markers, all these areas that look hepatoid in appearance are actually just typical biliary proliferation by immunohistochemistry. This is again somewhat similar phenomena where the ductular growth pattern or glandular architecture is not evident. These are solid nests of cells and can mimic hepatocellular carcinoma, where doing the right markers can be helpful. Some of the cholangiocarcinoma can be very, very poorly differentiated, as shown here. Sometimes they can have a spindle cell component where they look sarcoma-like or sarcomatoid cholangiocarcinoma. And again, in this setting, either the clinical setting or prior biopsies or immunohistochemical markers, all of them, sometimes in molecular, could be helpful in getting the right diagnosis. Sometimes you can just what you can say is just that this is a poorly differentiated carcinoma. So this is a chart that I just put for the sake of completion. These are the different variants of cholangiocarcinoma that are now described in the WHO. And as you can see here, there are quite a few of them. And as the name suggests, you can look at the morphology and the key features on the right side. So when you see cholangiocarcinomas, one of the things that comes up in practice is differentiation for hepatocellular carcinoma. And this is something that is a small kind of table that shows how to differentiate between these two. And this is clinically very important. And one good thing is that the immunohistochemical markers that we have available today are fairly good in differentiating hepatocellular carcinomas from cholangiocarcinomas. So the first distinction starts from the clinical story. As I said, hepatocellular carcinomas are the most common neoplasm, primary liver neoplasm in cirrhotic livers, whereas cholangiocarcinomas tend to occur typically in non-cirrhotic livers. Grossly, these tend to be more soft, tan yellow or bile stained, whereas cholangiocarcinomas tend to be more firm or gray-white. I just showed the classic, histology is very different, and nobody has problem when you have a classic histology. However, cholangiocarcinomas can become solid or hepatoid, and some hepatocellular carcinomas can have pseudoacini or pseudoglandular pattern, and that's where the problem comes. There are a variety of histologic markers that are available. Immunohistochemical markers that are available that help you differentiate between cholangiocarcinoma and hepatocellular carcinoma. Of these, there are many listed here. I would say that practically most of the labs will have HepPAR1 or arginase, which are probably a combination of those two would be, I would say, most sensitive and specific to differentiate cholangiocarcinoma from hepatocellular carcinoma. There are others listed here. Polyclonal CA, CD10 tend to show canalicular pattern, are fairly good. Alpha-fetoprotein is not a very good marker because it shows a lot of background staining, and then the antibody is not easily available in all centers, and even in cases that have high elevations of alpha-fetoprotein, the tumors may be completely negative. However, a new methodology which shows alpha-fetoprotein by in situ hybridization, which is called AFP RNA scope, there's still scant literature on this one, but appears that this can be a highly sensitive and specific marker for hepatocellular carcinoma. Glypican-3 is a marker of malignancy and hepatocellular carcinoma both combined. However, is only positive in more moderately and poorly differentiated hepatocellular carcinoma. Its positivity in some of the well-differentiated tumor is fairly low, and in that setting it may not be that useful. Glutamine synthetase and CRP are generally not used as a marker of hepatocellular differentiation, but if you see them used and positive, they are glutamine synthetase particularly can be more often in hepatocellular carcinoma than other tumors. CRP is not very useful, I think. CRP can be positive in hepatocellular carcinoma as well as cholangiocarcinoma. Unfortunately, there are not many specific markers that are good for cholangiocarcinoma, and of all the markers that are there, many of them are very generic markers that are good for cholangiocarcinoma, but still not specific enough for cholangiocarcinoma CK7 and CK19, because a subset of hepatocellular carcinoma can be positive for those. But in practice, again, these are fairly useful and more easily available. HNF1 beta is a newly described marker that is present in cholangiocarcinoma and some other adenocarcinomas, but not in hepatocellular carcinoma. So this can be useful marker if you have it. BAP1, loss of BAP1 can be useful in the diagnosis of cholangiocarcinoma. Again, a marker that is not easily available. Albumin-ish is a marker that is positive in both intrahepatic cholangiocarcinoma as well as hepatocellular carcinoma. So while it helps to differentiate between primary hepatic tumor from other tumors, there are only a few exceptions. This is not a marker that helps to differentiate between cholangiocarcinoma and hepatocellular carcinoma. Other markers like CD5, MUC1, polyclonal CA, these are listed, but I don't think they are that useful in clinical practice. The other issue when you're dealing with the cholangiocarcinoma is differentiation from metastasis, and that is a real practical issue because, as you know, liver is the commonest site for metastasis of all tumors, and tumors from various sites. If you look at the common ones, lung, pancreas, GI tract, and GU tract tend to metastasize in the liver. And the problem is that many patients present first time with metastasis, and when you look at the liver biopsies in those patients, your job is not only to diagnose the malignancy, subtype it, but also to tell what is the possible primary site for that metastasis. Now, approach to the metastasis is a separate lecture. Someday we'll talk about it. But bottom line is that when you look at these metastases, the first thing is to classify them by morphologies and growth patterns. And if you divide them by growth patterns, the most common growth pattern or the type that you see is metastatic adenocarcinoma. About 70% of the tumors that you see in liver that are metastatic are adenocarcinomas. Then others are composed much smaller percentage. Either they are poorly differentiated carcinomas, some are squamous cell carcinomas, or there are other types of poorly differentiated other malignant neoplasms. And when you look at the kind of clinical pathology correlation between cholangiocarcinoma metastasis, so growth is not helpful. The background liver is not helpful. The only thing that sometimes is helpful is that when you see multiple lesions in the liver, probably metastasis, but cholangiocarcinomas or primary liver tumors can be multiple as well. The histology is not very helpful. The staining pattern or immunohistochemical markers again are not very specific when it comes to differentiation of cholangiocarcinoma metastasis. However, I'll show you later on the kind of things that you can use. For diagnosis of cholangiocarcinomas, as I mentioned earlier, HNF1 beta, loss of BAP1, or if you have albumin-ish, these are the three markers that you can use to separate cholangiocarcinoma from metastasis. HNF1 again is a good marker, but it is known to be positive in a variety of other adenocarcinomas. By no means it is specific. BAP1 again by no means specific. Of these, albumin-ish is probably the only one which is the most specific, but again not 100%. There are other tumors besides hepatic carcinomas and cholangiocarcinoma that can be albumin-ish positive rarely. So again, I think it boils down to combination of markers, the clinical pathologic features, and identification of other specific markers that help you point towards a particular primary site. And this is a long list. I'm not going to go through this entire list, but what it shows you that when you are dealing with metastasis, you have to use based on the morphology and the clinical features in a given patient as to what are your possible primaries. Then based on that, you can choose from a wide panel of markers a panel that will help you sort out the differential diagnosis. For example, for colorectal carcinomas, you have good markers like CDX2 or SATB2 or Willen that help you kind of make a diagnosis of colorectal or possible GI primary. Similarly, when you're dealing with breast or Mullerian primaries, GATA3 can be a marker which will help you differentiate between those. So bottom line is that for each one of those categories and each one of those site-specific markers, depending on the morphology and the clinical setting, the gender of the patient, you will have to choose a panel that will help you narrow down your possibilities. And I would say that by judicious use of clinical pathology correlation and IHC markers, you can sort this out in more than 95% of your cases. These are again just to show you some of the commonly used markers and their pitfalls. And as you have heard many times, that none of the markers that you use in practice are 100% specific. So the important thing is that we're using those markers to know their potential pitfalls and false negative and false positive. So going back to our two cases that I showed you earlier, the 62-year-old man with 1.5 centimeters subcapsular liver mass in non-cirrhotic liver. If you remember, this was the histology at low magnification. This was the histology at high magnification. Very bland looking lesion, respecting the borders, very uniform distribution of the ductal proliferation, very banal cytology, although there was some sclerosis, but preservation of the native portal tracts and normal boundaries. So in this particular case, the diagnosis is a bile duct adenoma on needle biopsies, and I have to say that this can be very challenging diagnosis, and some of these lesions can look like bile duct adenoma in one part of the lesion and be a cholangiocarcinoma or something else in the other part. So when you're looking at the biopsies, one has to be very careful. You have to know the size of the lesion. If the size of the lesion is more than 2 centimeter size, be guarded in your diagnosis. You have to always consider sampling variability. However, if all the things point towards a benign lesion, you should not be hesitant in saying that this lesion could be a bile duct adenoma or is a bile duct adenoma, because in many of these patients, resection may not be an option, and all you need to do is just wait and watch. The second lesion, which was fairly similar looking but with slight differences, and I'll show you again the differences. This was the lesion. As I said, that most of the areas look like a benign lesion with a well circumscribed border and respecting the normal outline or normal relationship with the hepatic parenchyma, non-infiltrative, bland looking, uniform proliferation, looked like hepatic or bile duct adenoma in most of the areas. However, had some atypical features like pleomorphic cells, infiltrating borders in some areas. Again, to show you the marked pleomorphism and an infiltrative nature, presence of mitotic figures, as shown here. This was a lesion which focally had high Ki67 also, is actually a cholangiocarcinoma, and based on the morphology, I felt that this was cholangiocarcinoma probably arising in a bile duct adenoma. However, the small areas that I showed you, irrespective of whatever the background lesion is, one should call this cholangiocarcinoma. In this kind of a setting, if you are thinking of metastasis, obviously you can do the markers that I suggested. Hepatocellular carcinoma is not a real, differential diagnosis in this particular case. But again, if you were to worry about that, the markers will help you very well in this setting to differentiate the two lesions. So with that, thank you very much for your attention. I hope I have been able to show you all the kind of bile duct proliferations in the liver, benign to malignant, and sort of highlighted the different kind of lesions that you see in liver and how to differentiate between those. And in the end, like we say all the time, that it is not one thing or one feature or one particular finding. It is a combination of everything that helps you get to the right diagnosis most of the time. So thank you again, and I'll be happy to take any questions.
Thank you, sir. Thank you for this excellent and very comprehensive talk on such a difficult subject. If there are any questions, I could pass them on to sir. Or you could unmute yourselves and ask the question yourselves. While they're thinking, sir, I'd like to ask a few questions myself. Sir, sometimes we have biliary atresia in neonatal, like pediatric liver biopsies. We have biliary atresia with congenital hepatic fibrosis or ductal plate malformation. So, what are the clues to diagnose biliary atresia with a ductal plate malformation?
Yes, that is a very difficult situation. So I think this is slightly away from this topic, but I'll tell you that biliary in biliary atresia, when you get the ductular proliferation, in some cases actually it can mimic ductal plate malformation very closely, especially when you see them at advanced stages when they are very close to being cirrhosis. The biliary proliferation can mimic the a congenital hepatic fibrosis, particularly less often Caroli's disease. So I think in this setting, there are two things which are very important. And again, the classic cases I don't think is still a problem, because in classic cases in ductal plate malformation, the bands of bland fibrosis that you see that separate out this very irregular geographic nodules of hepatic parenchyma, and the ductal proliferations do have that kind of an inspissated bile secretions and irregular profile, whereas in congenital in biliary atresia they are more like regular ductal proliferations that you see in extrahepatic ductal obstruction. But again, I'm talking of the cases that have a lot of overlap and where the distinction become really difficult and you have overlapping features. In those particular cases, one, clinical knowledge that the patient does have biliary atresia, and nowadays they're very good with that because of so many advances that have taken place in imaging and clinical things. That is the key thing, that the patient does have biliary atresia, and I have not come across any case that has both in the same patient so far. So once you know that the patient has biliary atresia or complete bile duct obstruction, that is number one. And second thing now is that some of these patients do have germline mutations. So if you can do the mutational studies, probably that can be helpful as well. But largely, I think presence of bile duct obstruction and biliary atresia on clinical grounds is very important. The other thing which is also important is that the ductal plate malformations tend to present slightly later in kids, especially with portal hypertension, whereas biliary atresia presents much earlier in kids, usually with features of what can I say, liver enzyme abnormalities and cholestatic features fairly early in life, whereas congenital hepatic fibrosis and others tend to present much later in life compared to biliary atresia.
Yes.
Thank you, sir. Does that answer your question?
Yes, sir. Yes, sir. Sir, Dr. Minesh Gandhi wants to find out how to differentiate fibrolamellar HCC from cholangiocarcinoma on frozen.
That's also a very good question. Now, things that can be similar between a fibrolamellar carcinoma and a cholangiocarcinoma are the background collagenization of the stroma, which can be fairly similar in both, and if you are thinking of an abnormal or unusual variant of cholangiocarcinoma that has oncocytic features, the differentiation can be even more difficult. However, when you think of hepatocellular carcinomas, first thing is clinical. Fibrolamellar carcinomas tend to occur in younger individuals, and cholangiocarcinoma is a tumor of the elderly. Although I would say that we have seen probably rare examples of fibrolamellar carcinoma also in slightly older individuals. But by and large, most of the fibrolamellar carcinomas are in very young individuals, whereas cholangiocarcinomas, invariably patients are above 60 years of age. That's one. Secondly, background liver is non-cirrhotic in both most of the time, so that doesn't help you. But if you look at the morphology of the cells, the oncocytic thing is common in both, but the fibrolamellar carcinomas generally tend to have very, very prominent eosinophilic nucleoli that are characteristic feature of the neoplasm. In addition to that, they often have what are called the pale bodies. Those are intracytoplasmic inclusions that are again characteristic but not pathognomonic of fibrolamellar carcinomas, present in most cases. If they are present, they will be helpful. And more importantly, on frozen section, many times you don't even need to differentiate. I don't know why you have to differentiate between cholangiocarcinoma and fibrolamellar carcinoma. Most important thing when they are doing a frozen section on a liver tumor is to know whether they have got the tumor or not. First of all, that's why they do a frozen section in those cases, and generally for margins. Characterizing or kind of differentiating different kind of liver tumors on frozen section, except for metastasis and primary, that's a different issue, but is generally not a clinical important things. If you are wrongly called, let's say, fibrolamellar carcinoma, a cholangiocarcinoma on frozen section, the management should not differ at the time of surgery. They are both to be completely resected with negative margins. And you can always make your final diagnosis on permanence with full histology and immunohistochemical markers. So, does that answer your question?
Yes, sir. Yes, sir.
Dr. Gandhi?
Yes, sir, it does. Sir, another one more question. Last, I'd like to ask: the cholangiocellular variant, is it synonymous to the cholangio-low cellular variant? Are they the same?
Yeah, yes. I think these have become tongue twisters and sometimes very confusing for everyone. At this point of time, I don't personally use even the terms. Some people do use the term cholangiocellular carcinoma, and I think cholangiocellular carcinoma and what is the other one? Cholangiocellular carcinoma. Yeah, so ductal plate-like malformation or ductal plate-like cholangiocarcinoma has been used slightly differently than cholangiocellular carcinoma, although some cases do have similarity. I think the confusion came from the fact that some of the cholangiocellular carcinomas were very well differentiated lesions and tend to show some of the stem cell-like markers, and
Yes.
when people were very much kind of into this whole stem cell field, some of them were classified with the stem cell, origin of hepatocellular carcinoma. So I think that probably created a lot of confusion and sort of muddied the field a little bit. However, I think besides knowing that these are actually just variants of cholangiocarcinomas, to me there is no
Yes.
other practical significance of knowing this.
Yes. So they would be the small duct ones which are positive for NCAM,
Correct.
like you showed on the table. Okay.
Exactly.
Sir,
They are small
yes.
duct type, and I think
Yes,
beyond saying that these are cholangiocarcinomas and they tend to be well differentiated, saying that they are well
Yes.
differentiated cholangiocarcinoma, I don't think there's any other practical significance
Yes.
between those.
So Dr. Rajiv Kaushal wants to know if there is any comment on TTF1 expression in cholangiocarcinomas, your experience.
Yeah, TTF1, as you know, can be positive in many adenocarcinomas besides lung, and when you see TTF positivity in any adenocarcinoma in the liver, you have to be careful. I think TTF1 can be cytoplasmic positivity in some hepatocellular carcinomas as well. The TTF1 positivity can be seen in some other cancers. So honestly, I have not seen a TTF1 positive cholangiocarcinoma, but again, I think this is one marker like HepAR1, which is a very good marker for hepatocellular carcinomas. None of the markers are actually specific. So my suggestion for those things is that don't you go by one marker only. Either use a panel of markers and histology, or keep your mind a little bit open and not be very rigid about suggesting a differential diagnosis. But I haven't seen a TTF1 positive cholangiocarcinoma, but I'm pretty sure if you look in the literature, you will find, like anything else, rare examples of something in something.
Okay. Thank you, sir. Thank you for this excellent lecture once more. And I'd also like to read out some comments on the YouTube channel. Dr. Manoj Chaudhary, he's thanking you for an excellent discussion and for sharing these challenging cases. Dr. Hemachandran is also, he has written very good description of details, and Dr. Pooja Bakshi says that this is a very challenging area that has been explained well, superbly explained. So these are all the appreciative comments on YouTube and on the Google chat.
No, no,
So if
thank
anybody
you
else,
very much.
thank you, sir.
Thank you very much for attending the lecture, and I hope this is helpful. I'm sure that there's some things may I have left out in this broad topic, but at least try to cover some of the important ones that people might face in clinical practice. So enjoy that, and till next time, bye bye from
Yeah,
US.
thank
Thank you.
you. Thank you so
Thank
much,
you. Thank you.
sir. Wonderful presentation. And thank you so much for taking out time and explaining this in such a nice way. I think a lot of confusions have been sorted out. It is more challenging for us to handle benign lesions than the malignant ones. The malignant ones are like the positive malaria slides, which if it is there, it is there. It is when the malaria is you not see the slide, then the difficulty starts coming. So it's more important for us to address these benign lesions and not to call them malignant at any given point of time. And I think you have done a very good job by explaining those so clearly to us. And I think all the liver pathologists here would be so benefited with that. Thank you so much, Dhanpat sir, and thank you so much, Sunana, for
Thank
consenting
you.
to moderate this session. Wonderfully done.
It's an honor
Would
for
like
me. Thank you, sir.
thank you everybody who had come in and joined, and in the YouTube and on the Google Meet. We've got some very big names here, and Dr. Ashok Malik says very nice presentation. Manish Gandhi says everything well explained. Thank you so much, Dhanpat sir, and I think we'll catch you again. There is definitely an institutional and a national responsibility for you to keep coming again and again and trying to teach us so many things which is there for you to teach us. And I think that's it. So thank you once again, everybody. Good night for the people in India and good day for all those in US. Right? Bye bye. Thank you so much. God bless you. Bye bye. Take care.
Bye. Bye.
Bye
Bye.
bye. Take care.
Bye. Bye.